Lucy, our friend here, has some interesting filler challenges. She's had some skeletal maxillofacial surgery in the past, and she has a defect here, which is not uncommon. And there's numerous ways to treat this, but today we're going to put some filler in there. So we're going to use a large particle thick filler. She also has atrophy in the really the infraorbital region and in the tear trough region, and some submalar or infraorbital atrophy as well. And so we can, just by displacing some tissue there, you can see how that improves the situation. And she has a little bit of a dorsal hump, which she would be a good candidate for some filler rhinoplasty. So step A is to do our marking and anesthesia, and then we'll do our actual filler. Look at the areas that we're going to desire augmentation, and that's grossly our area there. Initially, this defect stands out with this extension being related to it. And again, the big challenge with filler is generally the volume that you can use, and the limitation is usually expense. So these are the areas that we're going to treat, and then my secondary or tertiary area, depending on how much filler we use, would probably go down into this region. I published an article in Dermatologic Surgery several years ago, give me a face implant, about using a cheek implant as a template for filler. And this is a good area to illustrate this, where you can actually take an implant and trace it out on the face, and then that gives you the almost a perfect template of where to put that filler. So now we'll proceed with the local 100,000 epinephrine, a 32 gauge needle. And what we want to do is to take the edge off of our other injections. And when you're talking about filler and anesthetizing the area, you don't want the lidocaine to become your filler and distort the tissue. So you don't want to inject too much. So I like to inject it deep, and just a little bit. It doesn't take that much. And we'll just put maybe 1 or 2/10 of a cc here in the anterior maxillary region. Now for infraorbital nerve block, the infraorbital nerve is about at the level of the lateral limbus, 5 to 8 millimeters below the infraorbital or inferior orbital ridge. And with this 32 gauge needle, it's usually not too uncomfortable to perform these blocks.
You got that one.
All right, all right, very good. So, okay, so we're going to begin here on the mandibular defect, and I'm going to pull it up over the mandible to give me a little bit more of a stable base. And for anybody that's familiar with topographic maps, how they have concentric circles that are wider on the bottom at the base of a mountain, and then as you approach the top of the mountain, the circles are piled on each other and become thinner. That's sort of the same type of situation that I want to do here. So we're going to certainly layer this filler, and right now I am more in the subcutaneous plane, and it looks real bumpy to you right now for several reasons. One is that I'm putting the skin under tension, and I'm going to coalesce this with some massage in a second. And this is going to be sort of my basal layer. And I've made the statements many times that on some patients fillers go further than others, and I'm not sure if that has to do with the thickness of the dermis versus the epidermis, the amount of subcutaneous fat, but on this patient it's actually going pretty far. We've used just over half a syringe, and I've got definitely a noticeable result here. So we will continue on this line, and we have 2 syringes budgeted for this area. so we'll be able to do a lot with it. You can see how I have my needle bent at a 45 degree or a little less than 45 degree angle, just so ergonomically I don't have to bend over, crane my neck. The facial vein and artery are in this region, as is the marginal mandibular nerve. But again, we are pretty much here intradermal and subcutaneous. And the massage with filler is just as important as the filler. And that's an impressive correction with one syringe. And a very impressive correction. Now, again, I'm going to kind of go deeper, and I want to contour this just because where it lies on the face, it's okay to protrude laterally. In other words, I would actually, in the final analysis, want this to stick out as opposed to just fill a void. I want some prominence here. And in the normal patient, it would be their flared mandibular border or masseter muscle that would provide that prominence. Okay. And this is Perlane, which is a large particle filler, so it should provide a nice consistency as well as longevity for this area. Now remember, most patients do have a mandibular notch, so I don't need to obliterate this entire region. All right, so there is 2 cc's of Perlane, and now we have a good prominence here that would mimic her masseteric region, and from the side we've restored that contour. It's probably somewhat difficult to tell. Put your chin way up because the lighting, but that worked out quite well. To the infraorbital anterior trough region, and we've done an infraorbital block. Is that uncomfortable?
A little.
Okay. And when we're injecting periorbitally, you want to use very little syringe pressure, and you want to really inject slowly. And I like to inject as I am coming out, because you want to avoid intravascular injection. You can see how nice that is looking here, a little pinch. Got the angular artery in this area and the infraorbital neurovascular bundle.
Yes, you do.
And that's a really nice correction here, although she feels it. So massaging this now, we have put 1 cc in this infraorbital depression in her tear trough. We may come back and put a little bit more, but if you look at this side versus this side, I believe you can see the difference. She has some nice malar or submalar anterior maxillary infraorbital projection now. And so we'll proceed on the other side. I want to be in the periosteal region. So I want to be deep for sure to the orbicularis oculi muscle. And so we're going to go back here, and we're going to slowly inject. And I'm using Restylane for this injection. You can see how nice it's plumping. So when people discuss layering of fillers, that's fine. But again, I think when we inject, we're always layering fillers if you're doing it correctly, because they do better in multiple tissue planes. So you can see here that my markings are really everything in terms of my augmentation. And this is an excellent patient, because even with the blocks and the infiltration, it's a little creepy to have somebody inject these areas. And we're almost finished here. I tell these patients to expect bruising. And then what we're going to do is we're going to massage. We're going to massage these areas out. And this is two syringes here. We've got a syringe on each side for the tear trough and cheeks. And now we're going to take a syringe. This happens to be Ultra Plus, so we're being very ecumenical today. We're using everybody's products. And we're just going to go back and add. And if you ever look at a cheek implant, this is about the exact shape of it. And what we're going to do is just add some filler here. And when you have the ability, we have a patient that will purchase the sufficient amount of filler to do a job, it is amazing what you can do with filler. And I'm not a proponent of, quote, liquid facelifts because I think it's a very expensive short-term fix. But for situations like this, there's no better non-surgical treatment. I could treat this patient with some customized implants, some off-the-shelf cheek implants, and a little facelift, but for a fraction of that price, she's going to get a nice correction here for a while. So it's a great little procedure, and fillers have really changed cosmetic surgery in the last decade. And it's important to have good overhead lighting because the shadows are really important as well. And if I've said it many times, and probably many times on this DVD, but if caulking came, or if filler came in a caulking gun, we could treat everybody to fruition. So we'll go back and we'll massage all these areas, and I think it's very apparent the positive changes that we've made. So now in finishing the contour of our cheeks, we're going to taper out over the lateral zygoma a little bit, and this is what the patient will notice when she looks in the mirror. She will appreciate that little prominence, because it really, if you don't have this, or if you had it in youth and you don't have it now, when you restore that, it becomes very apparent to the observer. And in terms of a little filler rhinoplasty, we're going to put a little dollop of filler over her
hump.
Yes, her dorsal hump. And you want to put a little bit above it, a little bit in the center, and a little bit below it. And it's a very malleable area. And there's a little hematoma that's in the making right there. I guarantee you that's a guaranteed bruise, so we need to compress this. And we'll do the same on the other side.